All right, so good afternoon, everyone, and thank you for joining us. My name is Eliana Landa, and I'm the Physician Relations Specialist here at Rothman. So today's webinar is with Dr. Kachooei, hand and wrist surgeon. Dr. Kachooei's office locations are in the Training Center, Innovation Tower, and East Orlando. Topic that he will be covering this afternoon is management and treatment options for tennis elbow. So just a few quick notes. At the bottom of your screen, you will see a Q&A icon where you can enter any of your questions throughout the presentation. And Dr. Kachooei will have time to answer any of them, as many questions as he can. Also in the chat box, I will share Rothman's phone number. So if you would like to make an appointment, as well as my information for any assistance that you may need. This webinar is being recorded and you will be emailed the recording within a few days. So without further delay, I will pass this off to Dr. Kachooei. Welcome, Dr. Kachooei, and thank you for your time this afternoon.
Good afternoon, Elena. Thanks for the introduction. And thanks for everyone who has joined, and hopefully it will be recorded. And those who didn't have a chance to join us, I know it's a busy day, weekday, we'll watch that later. And if there was any questions, I'll be happy to answer at the end and maybe later through my email. So the topic I'm covering today is tennis elbow, very common condition that I can say probably everyone will be somehow involved with that. My conflict of interest with the two journals I'm working. So the reasons for pain on the lateral aspect of the elbow. So we might experience some pain throughout the day, different activities. So from superficial to deep, going through different structures, all of them can be involved in causing pain. So the first one, which is almost the most superficial one, can be tennis elbow. And as we go deeper, nerve issues, which is close to that area, can cause pain. Elbow instabilities with ligament injuries called PLRI can cause instability of the elbow and pain. The other condition, which is very close to the tennis elbow condition, is plica in the joint, which is extra layer that is causing impingement, inflammation, and pain. So any trauma can cause fractures. It can be non-displaced, initially tough to diagnose and causing pain along the lateral aspect of the elbow. And arthritis of the lateral aspect, osteochondritis dissecans, and partial biceps tendon tear. Almost I can tell you that if anyone has lateral elbow pain, it's not out of this 8 diagnosis. So it's probably one of these 99.9%. So you can have this list of differential diagnoses and go through the list and rule out or rule in whichever you feel might be pertinent. So tennis elbow, different names throughout the time that it was defined as tennis elbow, because initially it was defined with tennis players, although it's more common in non-athletes like who perform repetitive motions. So the other names called lateral epicondylitis, then they realized not that inflammation. So enthesopathy of ECRB, the tendon that is affected. It's called tendinopathy, it's called periostitis, and many different names, and all shows that we probably still don't know why this happens and how we have to really manage that. And that's why we have different names, we have different treatment options. So interestingly, Syriacs in 1936, which is a long time ago, explained more than 26 different pathologies, including intra-articular or extra-articular pathologies, showing that there are different reasons that can end up to the same pathology. So what is the cause of tennis elbow? That's a very common question. Why this has happened to me? So we're doing all the daily activities. We're performing repetitive motions, as I said. The recent activities is basically on a computer working, depends on how the ergonomic of the workplace, and we place our wrists, we place our elbows. And what I always tell the patients, floating the elbow in the air and holding it up causes more damage and basically more stress and strain over your muscles, the muscle attachment. So the wrist position, all the ergonomics can put force, which is repetitive activities. Some if you don't have a good, basically, coach for lifting, bodybuilding, so we might do it wrong. Like the picture on the right side, you see the elbow is basically not along the side of the body as you see on the left, but on the right, you see the elbow is floating in the air, basically it's lifted. And as you're lifting the weight, that is pulling the whole arm down, which is stressing over the muscle attachment. So at the same time, the muscles that are crossing over the elbow to the wrist are straining too much force. And if that happens repetitively, or occasionally, with one time extra force, that can cause damage at the site of attachment of the muscle to the bone. Another activity that I've seen patients complaining after lifting a bag, like on the left side, you will see lifting again, the elbow is in the air. Also on the right side. So it's recommended if you're lifting something heavy, keep your elbows straight next to your body. So basically the elbow pit, which is in front, looks to front. So the electron, which is the back of the elbow, should not be turned outside, which is putting more stress. So going back to tennis, the name comes from tennis elbow. So the way we play tennis, coaches, they always tell about hints, how to do. So hard grip of the racket can put too much stress. Also, the way we do the wrist flexion. So I'm not a tennis player, but this is one of the activities that we do with the flexed wrist and at the same time extending the elbow. You saw that puts too much stress on the muscle attachment. So patients coming with lateral elbow pain and with repetitive motion, the activities that are not properly managed, there might happen some small tear at the insertion of the tendon. So the muscles that are attaching to the lateral aspect, the outside of the elbow, they are extensors of the wrist, which we call them ECRB, extensor carpi radialis brevis, and ECRL, extensor carpi radialis longus. So studies show that most and majority of the pathologies are at the attachment of the ECRB muscle, and some can be at the insertion of the other muscles, but majorly it's ECRB. So how do we know if it's, when we have the lateral elbow pain, if it's a tennis elbow or not? So there are two tests that when we see patients, we do the examination. One is Mills test with flexion of the elbow and pronating the forearm. When we bend the wrist, basically at the same time, we try to extend the elbow. It's a provocative test. Basically, we're trying to reproduce the activity that might cause a strain and pulling on the muscle. And the other test, you can also test, and the patients are also complaining with resisted wrist extension while the elbow is in extension. The patient feels pain under the thumb of the examiner. So that's easy to test. Patients usually have local tenderness. And if we do advanced imaging, visually X-rays may or may not show a little bit of a calcification at the attachment of the extensor tendon muscles. So occasionally we get MRI when the patient fails to respond, or if we plan for doing any surgical management, which on the right side, you will see the normal attachment of the common extensor muscle, but on the right side, there is a white gap between the muscle attachment, which is black, and the bone again, which is black, and there shouldn't be any white line between them. The white shows tear, maybe fluid accumulation over there that is showing irritation and repetitive injury to that area. Also, under ultrasound, it can be assessed, and like on the left side, you will see the normal attachment of the muscle, but on the right side, there is more heterogeneity of the echo by the ultrasound, which shows there's probably a pathology at the attachment site of the muscle. So how do we manage now? We got this pain, and it's really, a nagging pain, discomfort, bothering with daily activities. So the first thing, basically, whoever comes to us, number one, it's a benign condition, self-limiting. The first thing is reassurance. Sometimes patients are a little bit concerned about the pain and what that pain is, although this is very common that most of people know about tennis elbow these days. But the first thing first is reassurance. And the first two words that I always tell the patient is that this is a benign condition and this is a self-limiting condition. However, this self-limiting might take some studies up to 14 months. So that might be a little bit too long. So that's why we try to manage it in the meantime, depending on the pain level of the patient. So if the reassurance is enough, the patient only has occasional pain, which is tolerable, we can wait and give it time, especially if it's acute and within the first 6 to 8 weeks, the patient present to us. So we're expecting that the patient gets better on its own with no intervention. If it's longer than maybe 2 months, 3 months, there's a chance that it might take longer, maybe up to a year, until it kind of feels better. Sorry, the light turns on. So the second thing, when we see a patient, basically prevention is the second discussion with the patient. Prevention means whatever activity that is probably causing repetitive trauma or damaging the area and causing pain, either we stop doing it or do it in a proper way. If we're lifting something, we do it in a proper way. If we're working on a computer, so making sure that the elbows are in a proper location, proper position, the wrist the same. If we're doing tennis, make sure you have a coach and you're not just doing it on your own and get a tennis elbow. So we have to modify activities we're doing. There are also many activities and physical therapy that can be done, which include a stretching exercise. Basically, as we explain to the patients, these muscles should be stretched and at the same time strengthened in a proper way without overloading them, which is eccentric loading of the muscle. So if the patient is in the initial phase, usually the exercises can help. One common brace that everyone may have seen, and you can find it all in any market. It's a tennis elbow brace. Basically, it's not going above the elbow. It's meant to be over the muscle bulk of the forearm. And the whole purpose, basically, the theory behind it is when you put it over the muscle belly and you make it tight, you are unloading the muscle attachment, because the forces from your hand and the wrist goes up, and before reaching to the elbow, basically this brace is neutralizing those forces. So there will be less force on the attachment of the muscles on the elbow. That's why you feel less pain probably when you're using it. However, no studies showed a treatment effect for these braces. Maybe palliative, maybe initial phase, but usually we don't recommend braces for being used too long, because usually the negative effect is that they start causing muscle atrophy instead of strengthening the muscle in the long term. So short term, it's okay to use them. Another option that is some studies propose is nitroglycerin patches. And the theory behind it is that we know nitro patches increase blood flow, improve perfusion locally, and they're mainly used for people with heart issues. So they put it over the chest, and it showed that it improves the circulation, and if they have chest pain, that improves. Some other studies showed that if we use nitro patches over where we have tendinopathies or any tendon issues, which is more superficial, probably nitro patches also improve the blood flow and can help with the pain, number one, to go away. And also, if the healing is a little bit slowed down, maybe by improving perfusion, we can improve the healing of the muscle attachments. It's also used for Achilles tendinopathy. However, one of the adverse effects of nitro patches are headache and studies are limited and a little bit heterogeneous data about it. Not clear data that it really supports using nitro patches. It can be tried, but it's not proven yet if it's going to be helpful. Injections, we have heard about them many times, and we're using injections for different places. And I'm not really against injections. However, I'm going to talk about cortisone injections for the tennis elbow and the studies we have done, which might be a little bit detrimental in terms of the natural course of tennis elbow. Going back about history of cortisone injection, how it came into the treatment options for tennis elbow. There were some studies that are published historically, 1953, 4, 5, and they reported some good results with cortisone injection. So the question is really corticosteroid injection really beneficial or not? Again, going back to literature and research, the first randomized clinical trial was done in 1948, and the commercial release of corticosteroid was 1949, and the first use of corticosteroid in tennis elbow was done in 1953. Basically, that was the time we started to use it in medicine for treating tennis elbow. So the first RCT basically on using corticosteroid in tennis elbow, which is ECRB enthesopathy, was done in 1954. There were 2 studies published in Lancet, and one showed no effect, the other one showed positive effect. And since then, because research was not disseminated pretty well, and publication was not as sophisticated as this is today, once they were getting into the literature and getting published, it's hard to really prove otherwise that they're not right. So one of the first studies showed some improvement, but only followed up the patients for about 4 weeks, which is only about a month. Some showed improvement, some not. And the other study, 1957, which again showed some improvement, only followed up the patient up to 8 weeks. Other studies came to the literature regarding corticosteroid and placebo effect, and we did a meta-analysis looking at the studies published about corticosteroid compared to placebos. And over the years, we found 16 clinical trials, and only 3 of them showed a positive effect of corticosteroid, and the rest showed no superior effect of corticosteroid over placebo. And those 3 were only published initially in the beginning of the introduction of corticosteroid for tennis elbow, as you can see, 1954 and 57, with very low follow-up and low quality study design. So looking at 7 studies that had higher quality study design, at 1 month, the pain showed improvement, favored corticosteroid. However, DASH score, which is the functional score, did not show a difference, and grip strength did not show any significant difference either. And so that diamond, if it's crossing that dashed line, that means that there is no significant difference and favors no, nor neither the cortisone injection nor the placebo. So at 3 months follow-up of these patients, basically vast pain, no significant difference between placebo and cortisone, and DASH score is the same. And at 6 months, you will see that it's favoring more towards control group, the placebo group, and the diamond is moving to the left and crossing that dashed line, meaning that probably there's some recurrences coming back and having more pain at 6 months. So basically the conclusion was that there was no significant difference at 6 months in pain intensity between corticosteroid injection and placebo, and no significant difference for grip strength and function at any time. So maybe pain intensity got better, significantly lower after 1 month, but after that it was almost the same. So how about recurrence? We have heard about it. And after a couple of months, the patient feel improved, but they come back with recurrence of pain. We looked at our patients, 50 patients that had recurrence of tennis elbow, and looking at the pain level and the function. Basically, before they get cortisone injection, their pain level was average 4 out of 10. But when the pain came back as a recurrence, they were saying that their pain is average 5.9, significantly higher than it was pre-injection. And the DASH score was also the same. So the higher the number is, the worse the function is. So the number went higher, meaning that probably the patients are complaining of more pain. So average, they had 6 to 7 months of pain-free time, but these patients that had a recurrence, they presented with more severe pain. What I interpret that is basically we give them a little bit of a pain relief after about 1 month. So what happens then? So during this time, the cortisone is only alleviating pain, but it's not modifying the disease. So if there is any problem with the tendon, we're basically slowing down the healing phase. And before the tendon heals itself and gets better, the body tries to heal everything. We get a license to abuse. Basically, we don't have any pain. The patient feels better. Okay, now I'm improved. Now I can do the same thing or even more. Now let's go back to the exercise we have been doing. So you don't feel the pain even though that person is damaging the tendon attachment even more because the cortisone is still working and masking the pain in the area. So this license to abuse causes when the patient comes back with a recurrence, the cortisone's effect is worn off, the pain will be more. We get the MRI, we see even more tearing of the tendon attachments. So is it now worse receiving cortisone injection or not? So there are some downsides of cortisone injection despite that immediate relief of pain. So number one, painful injection, hypopigmentation, as you can see also on the picture on the right. So skin atrophy and hypopigmentation is one of the complications. Probably maybe cosmetic issue, but anyway, that is something which is happening. Expenses related, high recurrence rate, and worsening diabetes. If the patient is diabetic, cortisone can elevate blood sugar. And another word that is coined is medicalization. And what that means is that if I offer a patient to wait and see, the next time I see the patient, I can offer physical therapy, and the next time I can offer a cortisone injection and wait until we get to the surgery. But if we're going up a ladder and the first visit I offer cortisone injection, if the patient comes back, the only other options that I have at the next visit is either injection or surgery, basically. So I'm out of the other options. So this is called medicalization. So the more aggressive we start trying these benign conditions, the more aggressive we have to continue to proceed with those patients. So this is called medicalization. So we did one study looking at the charts and the patients who were diagnosed with tennis elbow. So looked at the surgery rate and also patients who have received corticosteroids before having a surgery, basically. And what this showed, you can see on the graph, the green line is patients who have had surgeries. We noticed higher rate of surgery for patients who receive corticosteroids. There are different reasons. It might be more severe presentation that the patient received corticosteroid and eventually ended up to surgery. But also we can interpret that as possibly medicalization, possibly license to abuse and causing more damage at the time of recurrence, causing and leading up to being offered surgery. So these patients that are receiving corticosteroid are at a higher risk of being offered surgery and undergo surgery. So is it worse getting corticosteroid? So one thing that was presented is about decline effect, and I just wanted to bring up about corticosteroid for tennis elbow is the decline effect that initially, as I explained, it showed promising results in 1950s. However, over time, different studies showed that this is not as effective as we thought, and probably the downsides are even more than the benefits. So the effects are fading over time, and we probably have to think about other options. So this is one of the patients after having multiple corticosteroid injections, and during the arthroscopy, we see that number one, the normal cartilage is probably gone. Maybe the reason for pain was not real tennis elbow, but anyway, the tissue is also very lax and too much damage along the lateral aspect of the elbow that we can see here. Another injection is PRP, platelet-rich plasma, and probably many people have heard about it. The application is for many musculoskeletal conditions. It can be used for lower extremities, for upper extremity, and for arthritis, and tennis elbow is also one of them. So far, the literature could show probably a significant effect in knee arthritis and somehow for tennis elbow. It's a little bit inconclusive for the other conditions, but for tennis elbow, this can be used. However, the disadvantage is it's very costly, so a little bit expensive. Still probably insurances are not accepting, it's not covered. But if it's possible to do it, probably worth trying. It's coming from patient's own blood, undergoing centrifuge, and the middle section, which is very limited amount of the plasma, will be separated, which has a high concentration of platelets and should be concentrated for about 5 to 9 times of the normal person's blood. So that increased concentration has some growth factors that might help. The theory behind it is helping with healing locally, basically when it's delivered in the local area. However, it's not 100%, so it's not a promising treatment, but literature showed that it can help probably in long-term run. Some studies showed promising results, and systematic review also showed significantly superior outcomes compared to steroid injections. Another injection is botulinum toxin, which the brand name is Botox injection, different applications. And the whole theory behind it is, again, like the tennis elbow brace we're using, this will be injected in the muscle belly, basically paralyzing partially the muscle. And when you're paralyzing, basically the forces are not transferring to the muscle attachment. So you're giving it some rest, the muscle attachment, not sustaining the forces for some time, probably about 3 to 4 months. Basically, you're giving it time to heal, if it's going to heal. So if it's not going to heal, repetitive motion. So basically, you're not doing anything. Studies showed improved outcomes after injection. However, one of the adverse effects within the first 3 months is weakness, which will be improved and resolved after 3 to 4 months once the effect of Botox is worn off. Going to the operative management. So some patients will fail all these managements eventually. And our study showed that 4 to 5% may be offered surgery. Basically, keep in mind 95%, which is a high number. As I said, it's a self-limiting condition, benign, and most of the patients get better, or at least get to the point that the pain is manageable. They don't need surgery. But what if they need surgery? So what do we see if we want to do surgery? So inside the elbow, we might see inflammation, which is synovitis. And with the arthroscopy of the elbow, we might see the other pathologies at the same time inside the elbow. But as I said, the pathology is basically at the attachment of the ECRB tendon. So there might be some other pathologies like synovial plica. On the left side, you will see inflamed plica, which might cause pain. So we have to get MRI, make sure we're assessing the patient properly, and we address the pathologies based on the findings. So on the left side, you will see the plica, and on the right side, you'll see that the plica is gone after shaving down, and the joint is clean, and the radial head is rotating free with no impingement and no inflamed tissue impinging there. So the patient improves if we find out the exact pathology. So this is not a tennis elbow, but can mimic tennis elbow symptoms because of the lateral elbow pain. So the synovial plica we usually see on MRI. So we have to be vigilant and on examination on MRI to diagnose that. So for tennis elbow, two major techniques are arthroscopic versus open surgery. There are some variations to either one. The major ones are arthroscopic and open. So what is the anatomy of this area if we decide to proceed with surgery, and what is happening during surgery? So this is the anatomy of the elbow, and this is the lateral aspect, the muscle, the common extensor tendon, extensor carpi ulnaris, extensor digitorum communis, and extensor carpi radialis brevis. All these three muscles creating common extensor tendon that attaches to the lateral aspect of the elbow. And if we draw a line and bisect it to two equators, above, which is anterior aspect of the elbow, ECRB is located. So we will find it over there, and that's what we have to address. Also below this line, we have the ligament LCL, which we should be cognizant and trying to stay away from that, because we don't want to cause instability of the elbow by addressing tennis elbow, causing another pain or another injury. So ECRB is right above this equator. That's where we have to address. So looking at the anatomy here. So the ECRL, the muscle part, which is only all the muscle fibers, is the ECRL. And the tendinous part comprises ECRB and EDC. Basically, that's where we need to address. So once we make the incision, we'll see the muscle fibers versus tendinous fibers, and then that's where we distinguish where we have to go for the approach. So once we elevate the muscle fibers underneath the tendinous part over there, and behind that can comprise the ECRB tendinous parts. So these fibers that are going oblique are the supinator, and this muscle bulk, the tendinous bulk, is comprising EDC and ECRB, basically, which is the posterior aspect of the elbow. Looking at the anatomy and the cadaver, so superficial is the EDC, extensor digitorum, that extends the fingers. If you lift it up, and that is the tendinous part, we see the ECRB. That's the muscle we need to address. And any muscle fibers not tendinous are ECRL, basically. Again, that is the interval we have to approach. So we're not doing anything with the muscle fibers at the elbows, level of the elbow. So ECRB is the one that we have to address, which is under the EDC. And once we remove that, underneath we see the oblique fibers of the supinator. During open approach, what we do is that the diseased part of the tendon, ECRB, that has the attachment to the bone, when we open that, we'll see fibrous tissue. The tissue does not look like normal tendon. That's what is causing pain. So we have to take it out, because that's a pain generator, basically. It's not healing anymore. That's the tissue that has stopped healing, caused scar tissue, fibrous tissue, and should be removed. Once we remove it, we need to repair anything that is left, the normal tissue back to close the joint. So what do we do during arthroscopy? Now we know where the ECRB is. Now probably we can also address it through arthroscopy. So if you look at the elbow from inside and the camera comes from inside looking to outside, what we see in front of the elbow is the ECRB. We discussed that it's located in front of the equator of the elbow. And looking inside the elbow from anterior, you will see the radial head, capitellum, and the ECRB is exactly the interval between the radial head and the capitellum we see. So, and that's the radial head rotating. We can test and examine the stability of the elbow. So the technique that I use and we published that it's when we get into the elbow with arthroscopy, we see some synovitis, which you can see here, some fraying of the synovium after shaving. So the needle technique to place the portal, getting the shaver inside the elbow, shaving the hypertrophied synovium and inflammation out, which can also be another cause of pain. Looking at other pathologies, if there's anything else to address. So we see the radial head and capitellum, and once we remove the inflamed synovium underneath, we'll see the ECRB tendon. Since we know where the ECRB is, one way is to piecemeal debride the ECRB attachment. That can be done with a shaver, piecemeal shaving, which might be time-taking. So mixing all these techniques together to unload the muscle, what I've done and published was using a knife, bringing it into the joint and gently being careful, not going beyond the equator of the radiocapitellar joint, making an incision, cutting the ECRB tendon, and basically unloading the attachment to the bone. If we see pathology over there, we can certainly address and shave scar tissue. Otherwise, just cutting the muscle, cutting the tendon, sorry, not the muscle, based on what we see, should unload and improve. During the healing and recovery phase, basically the tendon starts healing again after removal of the scar tissue, and patients should feel better over time. So the other thing is seeing another pathologist like a radial head cartilage fraying in a patient presented with tennis elbow and also fibromyalgia. So with arthroscopy, we may be able to address other pathologies. Our study that we looked at 15 patients with tennis elbow after arthroscopic tennis elbow being addressed, and using the same technique with knife technique, basically. So some improvements substantially within the first 1 month, which is expected because usually patients are not doing anything within the first months. That's why they say they don't have pain. But we should be mindful that recovery takes very long to get better. So maybe over 6 to 12 months. So even now I'm telling the patient that if you're doing surgery for tennis elbow, you have to expect doing physical therapy. And despite that you feel better, the force and pain takes long to heal, and it's not overnight improvement. So there are many studies comparing open versus arthroscopic management. Basically, all showed the same outcome between the two techniques. Maybe with the arthroscopic technique, we have smaller incisions, maybe less pain because it's a smaller incision, maybe less infection rate. However, complications rates are the same, function will be the same. And although, in my opinion, pain will be also the same, although some studies showed better pain improvements. So just with arthroscopy, we're able to see other pathologies and address them if there's anything else. And I would say after discussing all these treatment options, in conclusion, I will go back again to the first statement that if a patient comes in with lateral elbow pain, the first thing I will say to the patient is it's a benign condition and it's a self-limited condition. So if you can wait, wait, you don't have to do anything, and whatever you do is somehow palliative rather than disease modifying. So we're not modifying the disease, we're just palliating the pain. The second thing is reassurance, and starting with prevention, activity modification, ergonomics, and any repetitive motion at work, at home, or during sports. If we're doing, we have to modify those activities and give it time again to get improved. And if we want to address, try starting to manage, and basically calling it treatment. If you need to get short-term relief, maybe corticosteroid, but if you want to offer the patient a long-term relief, I recommend PRP injection. We know about 4% of the patients may end up to be offered and accepting surgery, and probably the arthroscopic and open surgeries are both having the same outcomes, and basically depends on the surgeon's preference, surgeon's comfort, and we'll get the same results out of both treatments. I'll be happy to answer any questions if there is any here, and also you can email me at amir.kachooei@rothmanortho.com. Hopefully no one gets tennis elbow, but I'm sure probably everyone has experienced tennis elbow somehow. So if you have any questions, we'll be happy to address that. So I think we're at 45 minutes, and if there are any questions.
We do have one question, Dr. Kachooei.
To the questions.
It says, have you had any of your patients be
So one of
treated
the questions, thanks, Jewel. Have you had any of your patients be treated with dry needling by a therapist in addition to traditional therapy in lieu of cortisone injection to alleviate pain in cases they may not be appropriate for cortisone injection for fall under medicalization? Yes, I would say I've had many patients that have done physical therapy. Certainly they get improvement. One thing that I want to mention here is regression to mean. And sometimes what we call it is basically, we don't know if that's the effect of the needling and therapy, or if the patient was not doing the same thing, was getting better over time. Basically, if that's the time healing, or if that's the intervention that is healing. So there are many studies, as I said, that the patients show improvement, but all the studies that followed up patients for a longer time, more than 6 months, all showed that after 6 months, patients are doing the same if they got placebo or nothing or intervention. So again, I can tell you that for short-term relief, certainly that helps. However, long-term, still we don't have any gold standard as a treatment. So that is called regression to mean. Again, I repeat that. The good thing with dry needling and physical therapy is that there is no detrimental effect. At least if the patient doesn't get any benefit, it doesn't get worse. So the only downside is, expenses that the patient has to spend, or the time that it has to spend if they don't get any response. I'm in support of physical therapy and dry needling, and also acupuncture. Occasionally, I send patients to acupuncture. I've heard good stories from our colleagues, occupational therapists and physical therapists. The patients are improving. Maybe some of the patients that we see, because we send the patients somehow, some of them, they don't come back to us. Some of them that they come back, they will say, we did physical therapy, didn't improve. Those that get improved, probably our friends and colleagues in occupational therapy, they will see they get improved, but we don't see them back. We have to probably do another study on them. So another question, are you seeing an increase in cases with the uptake in pickleball play? That's a good question. Pickleball play with clients that are not used to this level of activity. Actually, I'm seeing more fractures with pickleball rather than tennis elbow, because it's not, the ball is not very heavy, so the motions are not putting too much stress on the lateral, the attachment. The other thing is that I don't know, maybe it's done for now in the older ages that they're kind of slowly, they're not really doing high, they're not high demands, they're not proactive or pro athletes. Haven't seen that yet in pickleball. I've seen more fractures in pickleball. I'm doing pickleball too myself, but no, that's probably no for now. Thanks, Mahla, for how is your opinion about cell-based therapies like a stromal vascular fraction? Basically, yeah. So I don't have much experience actually. There are some like trials, not really. I don't know if we can say that it's part of the treatment options for now, but more of a trial. I can say different studies like patients' own blood without even doing a centrifuge, without even separating platelets, was injected in the same location, and the patients felt better. So we know that even with injection of saline, some patients get better. It might be placebo effect, number one. And number two, I remember that when I was reading one of these textbooks, uh, a good quote was there that the tennis elbow likes metal. Basically, metal means that if you put a knife in it, if you put a metal needle inside the elbow, probably whatever we do there, that causes some, it kind of triggers some healing, probably. So I'm not sure if that's really the autologous stromal cells that we are injecting, or if it's the effect of any intervention like dry needling just was brought up. We just put the needle in there, patients feel better without even injecting. So you can see all these types of injections we're talking about, saline, talking about PRP, talking about corticosteroid, even dry needling, which we are not injecting even. All of us have good experience. I've heard good stories about them. So that's probably regression to mean. It's time that is healing, not real. So now we can think about the cost and maybe psychological effect on the patient. So another question, do insurances cover PRP injection for tennis elbow, and have you seen any trend changes in performing PRP for tennis elbow? No, unfortunately, at least in my practice, it's not covered by insurance. Although there are some studies, I can say when I was looking at the PRP for different conditions, the only two conditions that literature could prove that PRP has a higher improvement rate than placebo and probably corticosteroid is PRP. However, because of it's too much expensive and insurances are kind of resisting, no, unfortunately. But if the patient is okay to pay out of pocket and is not ready to undergo surgery, I certainly recommend PRP, and I've seen good results with that. I haven't seen any increased trend in terms of injection, but the same trend I've seen. I don't have the statistics in my own patients, but I would probably say 70 to 80% improvements. So would you say treatment options are similar for medial sided pain as in golfer's elbow? I would say yes. Maybe medial side is a little bit more resistant, or maybe a little bit more arrogant. Maybe the patient population is a little bit different in terms of the type of activities compared to tennis elbow. That might be the reason. However, the treatment options that we recommend are basically the same. Number one, reassurance. Number two, activity modification. Number three, it can be managed with stretching exercise, injections, also the same PRP injections. I've seen good results. And the surgical management the same. So I would say probably the rates compared medial to lateral is 1 to 7 or 1 to 8 medial to lateral. So what is the typical protocol that you recommend patients to follow for progression of activity after operative management of tennis elbow? It's very slow. Basically, we have to move forward. So I usually, for the first 2 weeks, basically, just give them some rest. So some people put them in a splint, wrist splint, to hold the wrist in extension. I didn't find it really make a difference. I usually put them in a sling, but they you can put them in a kind of a splint to hold the wrist in extension, because we know these muscles are crossing the wrist and the elbow. So you're basically relaxing the muscle by holding the wrist in extension. So usually after 2 weeks until 2 months, I only do range of motion exercise, no strengthening exercise. So they can see physical therapists with some swelling control, range of motion of the finger, hand and wrist gently, and also the elbow, but no strengthening. And after 2 months, up to basically 4 months, they can start strengthening exercises. So as I said, the improvement will continue to 6 to 12 months. So you should warn the patient that going back to sport activities that might require too much forces, maybe after 4 to 6 months, depending on the improvement. So that will be kind of like the recovery time and how you will guide the patients. You can tell them 2 weeks, and then 2 weeks to 2 months, and basically 2 months to basically 6 months will be the time frame. So seems that we have addressed most of the questions.
All right, perfect. So if we don't have any other further
I
questions.
think another question, what do you think about advanced therapy like shockwave or deep heat? I'll have the same comment about the other types of therapies. As I said, there are too many studies out there, each one compared placebo with different modalities. Short term, everything works well. Looking at long term, everything will kind of come to equal level for the patient, which basically we don't know if that's the intervention we're doing. Is it the regression to mean? Is it the time healing? So certainly any intervention can possibly have a placebo effect, psychological effect. So we can take that. That's fine. If the patient has pain and want to take time and buy more time before we do medicalization, as I explained, certainly physical therapy modalities, other injections other than corticosteroid, which I'm against, and any other thing, totally fine. There is no detrimental effect, at least, except the monetary and the time that the patient has to spend. So thanks. What are your approach will be if a patient complains from radial tunnel simultaneously and tennis elbow? Tough question. Basically, I would say no one really, different approaches. Everyone has different approach, but it's hard to really prove it's a real radial tunnel versus tennis elbow versus both at the same time. Since radial tunnel is a rare condition, we never can prove it. Number one. Number two, nervous studies unfortunately cannot show radial tunnel, because it's usually the sensory component of the radial nerve, basically, that is compressed. So the radial sensory nerve, you can feel, you can palpate, and usually patients complaining of pain over the course of the radial nerve. I would say I've done patients with both pain and tenderness at both sites and improved with only addressing the tennis elbow. Sometimes I feel like those patients that have had a tear at the site of the tennis elbow because of the strain of the muscle, they might have some pull, and that causes stricture and tightness around the radial sensory nerve that can cause also pain and irritate the nerve. Once we address tennis elbow, basically, we're also unloading the same area. Probably that might be the reason. We don't have to address them both at the same time, but if you really have a strong feeling that the patient has both at the same time. So if it's a motor involvement, so the patient has motor involvement, meaning that wrist extension is weak, finger extension elicits pain, and the patient has weakness or drop of the fingers, certainly that's a motor component involvement. You have to address the radial nerve at the same time. But still no one can really address that. I would say if you're between the two and more towards tennis elbow, it's okay to only address one. but no one will tell you why you extended the incision a little lower and explored the nerve. So thanks. Seems like we're done with the questions. Let me see. Great, thanks. I think we're done with the questions.
All
Eliana,
right,
the
perfect.
stage
Well,
yours.
thank you all for taking time out of your schedule to join us this afternoon. And thank you to Dr. Kachooei for sharing such valuable information. I hope you all found this very helpful. And if you still have any questions, please email me, which you'll find in the chat box, and we will get back to you as soon as possible. Again, if you would like to make an appointment, please call 1-844-407-4070 or go to www.rothmanortho.com. Thank you.
Thank you, everyone, and have a good day.